Good morning, everybody. I'm Nona Baker, co-chair of MPN Voice, and I would like to give you a very warm welcome to our virtual forum from Belfast. We have a very exciting program this morning, which I'm sure so many of us will get a lot from, and I'm really looking forward to it. This, of course, couldn't be done without the help of all the clinicians. Dr. Allister Foy, Dr. Patrick Harrington, and Louise Gribben, the advanced nurse specialist, nurse practitioner, not forgetting our patient speaker. But I would also like to say a huge thank you to Professor Mary Frances McMullin, who has been with us virtually from the beginning of MPN Voice. And I don't underestimate your contribution to everything that we are achieving and have achieved with MPN Voice. Thank you, Mary Frances, for heading up this forum again. It's very much appreciated by everybody. This meeting is being recorded. If you don't wish your face to be shown on the video and uploaded to YouTube, please turn off your camera during the talks. There's still a chance to submit your questions to the panel. Please use the chat function to send your questions at any time during the event, and we will do our best to answer as many as possible. I think it's really important to stress that we can't answer any questions about your personalized treatment plans. Please speak to your consultant about that. Really important again, please remain on mute during the talk. Another thing that would really help us is if you could fill out the feedback survey. We are dependent on getting feedback from people watching the videos and the forums so that we can improve what we do each time. We've got a very busy agenda. We have 2 comfort breaks so everybody can get up and make a cup of tea and then come back. And we aim to close the forum on time at 12:30. Right, MPN Voice, I know that lots of you have seen this presentation before, but I think it's really important because we have new people watching this forum from Canada, Germany, Australia, California, Norway, Arizona, and France, to name but a few, who perhaps for them it's the first time they have logged in to one of our virtual forums. We started as MPD, a myeloproliferative disorder, a blood disorder support group, and it was formed in 2003 by a small group of patients, hematologists and specialist nurses and psychologists. It became MPD Voice in 2011 and then MPN Voice in 2013. The reason for those changes was when the World Health Organization reclassified the blood disorders as neoplasms. And so we had to change our name then. We're not a standalone charity. We're under the arm of, or the umbrella of Guy's and St. Thomas's Foundation. And that's just brilliant because they do all our governance for the Charity Commission and are immensely helpful to us. When the pandemic arose, we really had to up our game because one of the things that we feel passionate about is giving the community accurate information at all times. And so we had a massive restructuring in a hurry in March last year. And we have now an executive committee, which I co-chair with John Mathias, with Professor Harrison as medical director and Tim as our chief financial officer. We then have a management committee, a fundraising committee, an advocacy team, and this is really important too. We have a clinical advisory committee, of which Mary Frances is a member, and they play a really vital role in just guiding us through the correct information and what we should put onto the website and all that sort of thing. Coronavirus. My goodness, what a change this has been. You know, we've had to constantly update the website, Health Unlocked and Facebook. And we do realize just how hard and difficult it's been for the clinicians during this period. And that's why we're so grateful to them for giving time to do this for MPN Voice. We've delivered a lot of virtual forums, collaborating initially with Leukemia Care to deliver a webinar. We've also got some podcasts on the website, which are incredibly helpful and donated by a patient. We've done some surveys. We're keeping ourselves as up to date as we can and serving the patient community with the best possible information. There have been various studies that we've done, and one that is going to be talked about this morning, which I've actually been part of, and I'm very excited to and look forward to hearing Patrick talk about that. We will continue to publish as the results come through. What else do we do? Well, we do, as I've just spoken about, Facebook, Twitter, Instagram. We have a new person, Mark Taylor, who's responsible for all our social media. And my goodness, has he done an amazing job. We also have our YouTube channel, and this forum will be up on YouTube early next week, should you want to revisit and listen to the talks again. The patient forums. Maz and I were saying it's so sad we're not with you in Belfast, because we really enjoy the patient forum that we've done in Belfast. And we are hoping that we will be there next year, pandemic allowing and setting it up allowing. When we look at this, it's amazing actually how many people we've reached. In 2020, 1,627 people attended just 2 virtual forums and 2 webinars. That number will be a lot bigger this year, which is fantastic in a method to support the community. I've mentioned the people that are around the world at the moment, but we started as literally a small group of patients, as I said, at St. Thomas's, but actually now when we look at this map and look at the people who have joined today, we really are a global charity. And that is such an exciting thing for MPN Voice to be giving this accurate information and support. The research, research is key to our being actually, and most people as patients are very keen to support research. What I would encourage you to do is to go onto our website and look at the latest. There's a page on research, and you will be able to see all the research projects we're doing. And I'm not going to talk too much about that because Mary Frances is going to be talking about MPN Trials. Mosaic, this means a lot to so many people, the epidemiology study. And the centres in Ireland now are opening, and we've got centres opening. It's been difficult with the pandemic, but we are beginning now, and there are, the people ask, what's Mosaic done to date? And actually there are a number of papers that have been published that are widely circulated and used in the medical fraternity. Advocacy. This is another big area, that we have advocates who represent us on things like NICE and when decisions of drug funding are made. The recent work, the submission for NICE for fedratinib, we're also helping in Ireland the Irish equivalent of NICE for an appraisal of roxanitalib. There's an international group too. MPN Voice is a founding member of the MPN Advocates Network. This is again something where we are spreading knowledge, and knowledge is key. Fundraising. This is such a difficult thing because we are dependent on our fundraising. The funds enable us to fund research projects, run patient forums, although this forum, I have to say thank you to Novartis for supporting this, funding the website, updating the website, and there are many things that need money. And so we have a fundraising committee, And if you want to know more about that, and I urge you to, if you want to get involved, it is fun, please get in touch with through the link below. There are the pictures, and people do have fun. And actually now, last year, people were running marathons in their front rooms. Now people are able to get out, and the community is very active in raising these very much needed funds. Donations. We would be so grateful if any of you feel that you are able to, whatever, £1 or whatever, donate to MPN Voice. You will see we've got a new QR card there. So if you've got an iPhone or equivalent, you point it at it and you can make a donation. And if you want any further information, please contact Maz on info@mpnvoice.org.uk. Thank you so much for your support. You know, it means so much to all of us. And now it comes to introducing our first speaker. And I'm delighted to welcome Dr. Allister Foy, who's the consultant hematologist at Craigavon Area Hospital. And he's going to talk about, actually, I'm not sure what, I haven't got the title up there, but it will be good to hear you.
Okay. Excellent. Can you hear me and see my slides?
Yes, we can.
Brilliant. Hi there. Thank you very much for the invite from an absolutely fantastic charity, MPN Voice. I'm very honoured to be talking to you today. And what I was going to cover today, in the course of 15 minutes, which is no small undertaking, is an overview of myeloproliferative neoplasms. I work here as a consultant hematologist in Allister District General Hospital and Craigavon Area Hospital, and I see and treat a wide range of patients with MPNs. So what I was going to cover today would be broadly what are the MPNs, some of the key biology, the individual types of MPN that we recognize and treat, some of the signs and symptoms, and about how we identify and monitor symptoms and track symptoms, some of the key treatment strategies in the conditions, and then a very important topic of quality of life. So what the human body is a dynamic and controlled system. So if we were going to go for a run, our heart rate would increase, and that would increase the delivery of oxygen and all the nutrients and goodies that we need to all the muscles that are exercising. And the bone marrow is a dynamic system in a very similar way, in that if the body is experiencing challenges or changes in the environment, then it will respond likewise. So for instance, if we have an infection, our white cell count will rise, it will respond, it will destroy and deal with the infection, and then the bone marrow will switch down a gear and the white cell count will settle again. If, for instance, we cut ourselves and we have some bleeding, the platelet count will rise as a response to that, and then it will settle again. What we have in an MPN is that we have uncontrolled production of blood cells in the bone marrow that is irrespective of the challenges in the surrounding environment that the body faces. So coming from the Greek, we have a growth of blood cells in the bone marrow in an uncontrolled fashion. So in contrast to the previous diagram, what we have is that we have an uncontrolled production of a system which is permanently switched on, and it can produce red cells, it can produce white cells, it can produce platelets, all of them or some of them, depending on the different subtype of MPN that we are dealing with. The types of MPN broadly are divided into essential thrombocythemia, Polycythemia Vera, and Myelofibrosis, which can either be primary as an initial event or secondary coming after either essential thrombocythemia or Polycythemia Vera. And the fourth category, which I've deliberately put in smaller text, is an emerging subtype called Pre-Fibrotic Myofibrosis. The basis of this is acquired genetic mutations which affect bone marrow cells. And this diagram essentially shows that any genetic mutation that we acquire through life increases in frequency as we get older. So the older we are, the more likely that genetic mutations can happen by chance as cells and DNA are aging. And that is not just restricted to the bone marrow environment, that is restricted to this, that is a body-wide phenomenon. So we can see there that, you know, in the ages of 20 to 29, the frequency of acquired mutations is very low. And as we get older, up, you know, 60s, 70s, 80s, 90s, steadily the risk of these genetic mutations increases. The genetic basis of MPN is of acquired mutations, so not inherited, not passed on. They all act through this pathway called the JAK pathway in the bone marrow stem cells, which then leads to overproduction of these blood cells, and that leads to disease-related signs and symptoms. For example, blood clots through the overproduction of platelets. There are three main mutations which are known. There's the JAK2, V617F, and exon 12 mutations. There is MPL, and there is the third mutation, which was more recently discovered, called CALR. These pie charts just demonstrate that there is a lot of variability in the pattern and frequency of these mutations in the different conditions. For instance, Polycythemia Vera is predominantly a condition which is associated with the JAK2 mutation, whereas for essential thrombocythemia and primary myelofibrosis, the spread is a lot more even. And I will point to in the center there, the essential thrombocythemia, the ET light blue and the PMF light blue. Those are sections where none of the three mutations have been detected. So there are a number of people who have none of the three mutations but exhibit all the signs and features of the conditions. Deal firstly with essential thrombocythemia, which is primarily an overproduction of platelet fragments that circulate in the blood, and ourselves, these fragments will go to that site, plug the gap, and allow wound healing. An uncontrolled production of platelets that can present a variety of signs and symptoms. A persistent overproduction of platelets, usually greater than 400, is the cutoff in most centres as normal. 150 to 400 would be the usual range. There's a slight male predominance in terms of the number of patients that will have it, and it is commonest in those over 50 years of age, although I will say that I have patients below that age as well. Bone marrow produces too many platelets, which then circulate in your bloodstream. They then clump together and can block vessels, block small blood vessels, and hinder the blood flow, and that leads to an increased risk of blood clots, including blood clots in the legs, the chest, strokes, and heart attacks. The clinical features are very varied, and we'll discuss more about the clinical features shortly across the MPN group, because actually between the three different subtypes, PV, ET, and myelofibrosis, there is a lot of overlap in terms of the symptoms patients will get. Fatigue tends to be a predominant feature across the board, and itch is also one that I see very frequently. There are some other symptoms that can be related to sluggish blood flow, perhaps in the smaller blood vessels, such as headaches, an increased propensity to migraines, perhaps. Some patients will get tinnitus when their blood counts, when their platelet count is very high. And there's also a risk of strokes, or a TIA, which is essentially someone who gets the features of a stroke, but it resolves within a short period, usually less than 24 hours. Some patients can present, the first time that they get a diagnosis of ET is when they have a blood clot. Some people, platelet counts can rise very high to greater than 1,500, And in this scenario, there would be also an increased risk of bleeding as well as clotting. This is from the landmark study, which Nona had mentioned, which was an absolutely incredible study across a number of countries worldwide, America, the UK, Europe, and also the Middle East. And what this shows is that the predominant symptoms at the top here tend to be fatigue or tiredness. And the three colored bar charts, the yellowy orange, the red, and the blue, are the three different subtypes that we see: ET, PV, and myelofibrosis. And you can see that although there is some variability, largely there's quite a lot of similarities across all the different subtypes. So fatigue and tiredness tends to be one of the predominant features, but also point you to the middle here with pruritus, which is itch, tends to be quite equal among patients, and around 20 to 30% of patients will experience significant itch, which tends to be related to either changes in temperature, environmental temperature, or classically after a hot shower or a bath. Classically, we divide patients up into high risk and low risk in terms of trying to determine what the best treatment strategy would be. For essential thrombocythemia, when we refer to high risk, we refer to high clot risk or high cardiovascular risk or non-high cardiovascular risk. The focus really is trying to prevent complications related to the condition. And the two things that are recognized as high cardiovascular risk would be an age greater than 60 or a history of thrombosis. And what a thrombosis really is a clot. So if you've had a previous blood clot in the leg or a heart attack or a stroke, with a high platelet count, there is a higher risk that could happen again if your platelet count is not controlled. And that would be one of the reasons that we would intervene to try and control your platelet count. We're in the era now of molecular medicine, and we know that there are some differences which are emerging between the three different mutations that are associated with myeloproliferative neoplasms. Often it's seen that JAK2 carries some of the highest risk of clots, and uniformly patients will be given either aspirin, or many patients are on other blood thinners or antiplatelet medications if they were previously on them, or if they have difficulties taking aspirin, such as with heartburn. And then we know that patients with CALR mutations can be associated with a much lower clotting risk. And there's very much an individual risk-adapted approach to whether or not we use aspirin in those circumstances in those patients. In the high risk patients, those with their high cardiovascular risk, so greater than 60 years of age, or have had a previous event or high risk of a further event, then aspirin is used pretty much uniformly, along with cytoreduction. And cytoreduction just means that we use medication to reduce the platelet count back down to the normal range. And there's clear, good quality evidence that that reduces your risk of future complications. Polycythemia vera is associated with either an increase in red cells, usually, so that the majority of patients will have a high red cell count or a high hematocrit. You will often hear the physicians talking about, and they can also have high white cells and or high platelet counts. It's a prediction. It's the average age of diagnosis is around 60. And really, in a similar fashion to ET, it causes an increased thickness or stickiness in some of the smaller blood vessels, and it can increase risk of features can be similar to essential thrombocythemia, but the difference is red or rosy complexion very high. Control the hematocrit by taking blood off. Age, or if you're age and you're on other medications, well, we can use medication if you're high risk over 60 years of age, such as hydroxychloroquine or interferon. Use symptoms. Myelofibrosis, which you have inflammatory marrow, and it can occur either as the primary event, or it can occur after a long history of marrow then struggles to make the necessary things, and the spleen increases in size because it becomes the primary factory for making blood cells, and the spleen then enlarges and can cause symptoms of tummy pain, fatigue, high or low blood counts, itch would be, and is generally very large. You can treatment is very individualized. It's based on symptoms and blood counts, and we manage symptoms and transfusions, which will stimulate cells if your counts are low. Which was a real game changer, a real change forward in management of myelofibrosis, which is very effective at reducing symptoms and spleen size in patients with myelofibrosis. The landmark study, which I've mentioned, patients really wanted to assess symptoms and the effect of as a symptom assessment form, which is filled out by patients to help determine the effect of the MPN on their same slide essentially showing variability, but and those patients the MPN symptom assessment allows patients to grade the severity of their symptoms from 0 in terms of how they experience.
Hi, Allister. Apologies to interrupt. We're having a little bit of a problem with your sound. Is there any chance you could move a bit closer to the computer just in case that's
I can. Is that better?
Slightly.
Slightly.
Thank you.
Yeah. So what we see from the symptom assessment forms and the landmark study is that patients will experience quite significant symptoms, inactivity, fatigue, depression, or low mood, ranged in severity, on average about 5 to 6 out of 10. Symptoms that patients in that study of 600 patients worldwide that would most likely have had resolved were fatigue and tiredness, blood clot dissolution for those patients that had experienced blood clots, and bone pain in those with myelofibrosis, itch in patients with Polycythemia Vera, and strokes or headaches or migraines in patients with this. Impact of symptoms on quality of life. We can see that about 29% of patients in total strongly agreed that MPN symptoms reduce their quality of life. And then as we go down the lines there, you'll see that 11% strongly. We will see that on average, myelofibrosis patients were most likely to agree strongly that they experience symptoms that thrombocythemia, but still a quarter of patients with ET strongly agreed that the symptoms reduced their active work again. So 20% of patients hours at work, 9% of patients involved. See the impact of MPN on the lives of patients. Finally, just wrapping up, the monitoring of your condition, and this is really what I and my colleagues will look at whenever we're in the clinic, which is really about blood counts and the spleen and things. Is the disease well controlled? Is it progressing? Do we need to modify treatment, or can we reduce or stop treatment? Then central to all of this is understanding the condition, how the condition affects their symptoms, their quality of life, the variability. Is there anything that we can do, and anything that I can do to improve that, whether there's additional medications that we can use, or actually additional medications that we can withdraw, because some of our medications are associated with side effects. And to monitor patients on an ongoing basis for changes in their health or cardiovascular risk. And really the central key to this is building a therapeutic relationship with patients where we can openly discuss the challenges that they are facing and try and put steps in place to improve. Things are changing, as Nona explained. The world has changed beyond all recognition in the last 18 months. We are managing clinics and managing patients changed somewhat. Used to be very, very doctor-led, but now we have an incredible, and Craigavon is no incredible clinical nurse specialist here, which provides vital service here. It allows patients by telephone to be treated at home and less visits to the hospital. And then there's an emerging role for the internet, perhaps in terms of virtual consultations, or there's also an MPN symptom assessment form app, which you can use to also track your own symptoms as well.
Allister, thank you so much for your talk. Unfortunately, the internet, I know you mentioned the internet there, was playing up a bit and we couldn't always hear all of it, but you presented some really clear slides, and I'm really grateful to you for giving so much clarity to the various MPNs that we suffer with. Thank you again very, very much. And if anybody's got questions for Allister, please use the chat because I'm sure he will be able to answer them for you at the Q&A. I would now like to welcome Dr. Patrick Harrington, who is going to talk to us about the COVID vaccines and boosters. Patrick is a locum consultant at Guy's and St Thomas's, and a clinical research fellow at King's College, London. Welcome, Patrick, and I look forward to hearing this.
Okay, thank you for that introduction, and thank you to the team at MPN Voice for arranging this meeting and inviting me to speak. Can I confirm that you can hear me clearly?
Yes, we can.
Excellent, okay. So as mentioned, I'm going to talk about the immune system and how it's affected by COVID-19 in patients with myeloproliferative neoplasms. So a bit of background. As we all know, COVID-19 has caused unprecedented global healthcare challenges, and we know that the key to controlling this pandemic is through the development of widespread antiviral immunity, and this can either be achieved following infection or preferably through vaccination. So the three key questions that I'm going to address in this talk from an MPN perspective are whether patients with MPN are at an increased risk from infection with COVID-19 and from infection generally, whether patients with MPN respond adequately to vaccination, and following on from this, what level of antibody or T-cell response provides adequate protection. And I'm going to primarily discuss the data that we have generated from our own research at Guy's and St Thomas's with the support of MPN Voice. So that brings me on to my next slide. So there have been 3 major pieces of research that have been supported by the team at MPN Voice, looking at since the pandemic began. The first piece of work that we did was looking at the response to infection, and that was prior to the implementation of the vaccination program. We then went on to look at the response to vaccine, looking at both antibodies and T cells, and primarily focusing on laboratory data. And then we also performed a piece of work looking at the clinical response to vaccination, and this has led to a number of publications from our group. So briefly, just to try and summarize the immune system in one slide, which is even more of a task than trying to summarize MPN in 15 minutes. So the immune system is a complex network of cells that work together to defend the body against foreign invaders. And the arm of the immune system, which I'll focus on now, which is particularly relevant to vaccines, is called the adaptive immune system. This is broadly comprised of 2 types of cells, both of which are white blood cells, as mentioned in Allister's talk, and they are called lymphocytes. And these cells are called B cells and T cells, which you probably will have heard of. B cells are the cells that, when exposed to antigens or enemy proteins, go on to produce antibodies. I'll just get my pointer to demonstrate this. So you can see what, upon exposure to a foreign protein, the B cell goes on to be activated and go on to produce these little antibodies shown here. T cells, on the other hand, work differently, and these can be divided into 2 different types, broadly speaking, depending on the presence of different surface proteins called CD4 and CD8 molecules. CD8 molecules are also termed cytotoxic cells, meaning they can directly kill other infected cells, whereas memory T cells are called, whereas CD4 cells are called helper cells, in that they primarily are involved in helping other aspects of the immune system. And hopefully this will make the future slides that I'm going to discuss a little bit more clear with regards to some of the tests that we've performed. So a bit of background information firstly. We know that the immune system can be affected both by the underlying diagnosis as well as certain treatments used in MPN patients. However, we also recognise that this varies significantly between patient to patient. So the question as to whether patients with MPN are more affected by infections generally has actually been recently addressed by 3 large studies prior to the COVID-19 pandemic. Firstly, a study that was led from a team in Sweden compared the incidence of infection in over 8,000 patients with MPN, so a really great piece of work. And they compared the incidence of infection with that observed in healthy individuals, and they found that both bacterial and viral infections were increased in the MPN group. Following on from this, another study looked at around 1,000 patients, and they identified that a diagnosis of myelofibrosis and the treatment with the JAK inhibitor ruxolitinib are particular risk factors for developing infection. And finally, another study, which looked at 400 patients specifically with a myelofibrosis diagnosis, found that treatment with ruxolitinib, as well as high-risk disease as per the IPSS classification system, led to increased risk of developing infection. So moving on to address specifically whether patients with MPN are at increased risk from COVID-19, and there have been 2 studies that have published data on this thus far. The first of which was a study led across Europe, but led by the Italian MPN specialists, and they looked at outcomes in 175 patients and reported a survival rate of around 70%. So this would suggest a significantly increased risk compared to the general population. However, we need to be aware of 2 important caveats regarding these studies. Firstly, this is data prior to the implementation of vaccines, and we would hope and expect that the vaccines would significantly improve the outcomes from infection, and we'll go on to discuss that. But secondly, and even more importantly probably, is that the nature of these studies is that they are retrospective reports from hematology specialists, and so they are in their nature likely to be skewed towards more severe cases. The majority of patients with mild infection won't be brought to the attention of the hematology specialist at all, which will inevitably skew the data to an extent. With regards to the individual risk factors that they found in these studies, the normal suspects were observed, including age, male sex, and obviously ICU admission. But an important finding from the Europe-wide study was that ruxolitinib discontinuation led to worse outcomes in these patients, and that's shown by the image on the right. And what this could suggest is that ruxolitinib helps to control the inflammatory syndrome that is observed in some patients with severe COVID-19 infection. And actually ruxolitinib was being looked at as a treatment for COVID-19 at one stage because of this effect of controlling this inflammation. The second study was a UK physician study, just to briefly mention that, and that looked at 77 patients in total. And again, it reported worse outcomes in the MPN patients compared to the general population, again with the same caveats applying, and they found no difference in outcomes across MPN subtypes. So moving on to the immune response to COVID-19 infection. Our colleagues at King's College London published an important article that showed antibody levels declined significantly in the 3 months after infection with COVID-19. So in view of this data, we focused specifically and heavily on the T-cell response to infection and vaccination. And there's also evidence from the SARS-CoV-1 epidemic that T-cell immunity plays a particularly important role in immunity against these coronaviruses. So we were able to show initially using a technique called flow cytometry that there were presence of specific T cells that reacted to 3 different proteins from the SARS-CoV-2 virus, including the spike protein used in vaccines over 6 months after infection in some cases. And this is shown by the figures on the right, where each of these tiny dots represents a T cell from a patient with MPN. The plot on the top left here shows unstimulated cells that were not exposed to the virus proteins. However, the other 3 plots show a significant reaction when cells are re-exposed to each of the virus proteins being studied. And that's signified by these dots in the outer 3 quadrants of these plots here. These are reactive cells expressing pro-inflammatory cytokines, which are used as a surrogate marker of reaction against the the SARS-CoV-2 proteins. So it's a really meaningful finding that there's what looked like prolonged immunity in these MPN patients greater than 6 months after infection. We then began to focus on studying the response to vaccination. This is again in collaboration with colleagues at King's College London. We firstly studied the antibody response in 21 patients after a single dose of the Pfizer vaccine, and they were on a range of different treatments. We initially performed a standard quantitative anti-spike protein antibody test and saw a response rate in 76.1% of patients. But to further strengthen our research, we used another type of test called a neutralizing antibody test. So this is where we take different dilutions of the patient plasma, which contains antibodies, and we incubate this alongside viral particles expressing the spike protein, as well as cells expressing the spike protein receptor. And what we're measuring is the ability of the patient's plasma and antibodies in it to prevent entry of the virus into the cells. So it's a really functional test, and some would say it's more meaningful, including myself, more informative for us than the standard quantitative antibody test. And using this test, which detects more different types of antibodies than just the standard anti-S IgG, we detected a positive rate of 85.7%, so an increase. We also showed a significant correlation between the 2 types of antibody tests, which is meaningful from our perspective from an analytical point of view. Another study, just to mention, was from the Oxford group, again looking at the response to vaccination in 60 patients in total, with 35 of these having a diagnosis of MPN. They performed just a standard antibody test using the quantitative anti-S IgG. But what they did, they compared to the antibody levels observed in a group of healthcare workers, and they identified that the response rate in MPN patients was lower than that observed in the healthcare workers. But they did only report a rate of 58% being positive in MPN patients, which is quite a bit lower than what we had observed. This is again after just a single dose. They noted a reduced response in patients taking hydroxycarbamide and ruxolitinib, but the numbers of the patients taking these medications was very small and the data was not significant. And they also didn't observe a difference between the Pfizer and Oxford vaccines or between different MPN subtypes, as well as CML. Returning to our study from Guy's and St Thomas's, we performed T-cell analysis using the same flow cytometry technique in 20 patients after a first dose of the Pfizer vaccine. And in keeping with our findings from antibody analysis, we observed an overall T-cell response in 80% of patients. Using flow cytometry, we were able to assess the different types of T cells, as mentioned earlier in my immunology talk slide. And we could see that the response was predominantly a CD4 helper T cell response, as opposed to a CD8 cytotoxic T cell response. So this is interesting for us from a scientific perspective. The plots at the top right here demonstrate a strong T cell response in a patient with myelofibrosis on ruxolitinib, so someone who you would be considered to be very immune suppressed in view of these factors. On the left are the unstimulated cells again, and on the right you can see a significant reaction, particularly here, showing expression of this chemical messenger called TNF alpha, which is an inflammatory cytokine. Moving on to the response to a second dose, and this is again from our work at Guy's and St Thomas's. By this time point, we were able to expand our cohort to 61 patients in total, with 37 of these having an MPN diagnosis and the rest having a diagnosis of CML. We observed an increased rate of response from 76.1% to 89.2% between 1 and 2 doses. But this wasn't a significant difference, and this is to be expected given the high rate of response that we observed after the first dose. We also observed an increase in the antibody levels. The anti-spike IgG antibody increased from 1,012 to 1,466, and there was also a modest increase in the neutralizing antibody levels. We also observed an increased proportion of non-responders in patients taking ruxolitinib, as well as those receiving the Oxford vaccine. This is unpublished data, but it's something that we're going to submit very shortly. So hopefully we can expand on these findings then. Moving on to our T-cell analysis following the second dose of the vaccine. As mentioned, we'd had increased our cohort, and the flow cytometry method used previously would be too labor intensive to perform on 60 samples. I'd still be doing it now. So we used a different method called Fluorospot Analysis, in which you can do up to 45 samples at once. And it relies on many of the same principles in that you incubate cells with the spike protein peptides, and then you look for a reaction as indicated by chemical messages called cytokines, which are a surrogate marker of a reaction and a memory T cell response. And in any scientific test, you have to include a positive and a negative control, which is shown here, just to show that your test is working where it should be and not working where it shouldn't be. And each of these green dots that you can see represent a reactive T cell secreting these cytokines upon re-exposure to the spike proteins. So using this technique, we observed an increased response rate up to 88.3% in MPN patients. Another study that we've recently published in the Cancer Cell Journal looked at outcomes in patients who've had an allogeneic stem cell transplantation. And many of these patients had an underlying MPN diagnosis as the reason for their transplant. As you'll probably know, these patients are considered to be some of the most immune suppressed patients that we see, with many taking drugs specifically designed to suppress their T cells to prevent transplant rejection and graft versus host disease. The interesting finding from this study was that there was a minimal response to the first dose, in contrast to what we saw with the MPN and CML patients. So the positive response is shown by the yellow bars here. You could see after a single dose, not many patients had responded, but after the second dose, there was a significant increase in response rates. So the take-home message really was the importance of the second dose in this group of very immune suppressed patients. And you can see the antibody levels shown here after each, the average antibody levels shown after each dose, showing both the IgG and the neutralizing antibody levels, and a significant increase of the second doses. So it's quite a nice finding to reassure this patient population. And finally, just to mention a piece of work that was led by one of our physician associates, Jamie, in conjunction with the team at MPN Voice, including Maz and Nona, who are with us today and are listed as co-authors. This is a really impressive modern study using the internet to achieve 1,218 responses, which would otherwise be impossible during a pandemic with traditional methods. And what Jamie reported was an increased MPN 10 symptom score after vaccination, which is of note. And he also reported a very good uptake of the vaccine, with only 0.8% of respondents declining vaccination for various reasons. Even more meaningfully was that he didn't record a single case of the vaccine-induced thrombosis and thrombocytopenia syndrome, which is excellent news given the risk of thrombosis in this patient population, generally speaking, and the fact that 50% of respondents had actually received the Oxford vaccine, which is the vaccine that this syndrome is associated with. So that's very reassuring, given the large number of respondents. So just briefly to touch on third dose and booster doses and to give some clarification on this. So this is from Blood Cancer UK. In the UK, patients who are immunosuppressed have been offered a third dose. For Pfizer, this is actually exactly the same dose as the booster. However, for Moderna, this is a half dose. So as such, in our practice, for Moderna, the booster is a half dose. So in our practice, we're suggesting that if people are offered a booster instead of a third dose, to always ask for Pfizer, as in this case, this will be exactly the same. Those patients who do receive a third dose as opposed to a booster will be eligible for an additional booster after 6 months. So if possible, if you're considered to be immune suppressed, then I would suggest discussing this with your hematologist and asking for a third dose to be arranged. So finally, just to come back to our questions from the beginning, are MPN patients at increased risk from infection? The data we have on this would suggest that the answer prior to vaccination would be yes. However, it's unclear currently how much vaccination mitigates the risk in this group. And we have the upcoming hematology meeting in America in December, where some of the data from the clinical analysis following vaccination is going to be presented. So we should have more of an answer to this question then. The second question is whether MPN patients respond adequately to vaccination. And the answer to this would be that the initial laboratory data is very promising. However, there are some groups that need to be studied further, including patients on certain treatments who need to be studied a bit more in a bit more depth to find out why they may not be responding quite as well. And finally, what degree of antibody and T-cell response provides adequate protection? As yet, this is unknown, and this will require ongoing combination of laboratory and real-world data on the incidence of infections to answer this question, but hopefully we will be able to answer this soon. And that's it, thank you.
Thank you so much, Patrick. You know, on behalf of the patient community, we're so grateful for this research being done, because it is actually really reassuring for all of us to see this data and the ongoing research that's being done. So to all of you working in this field, a huge vote of thanks from all of us. It was really, really interesting. And I'm sure there'll be many questions in the Q&A.
Great, look forward to it.
Okay. I would now like to introduce our patient speaker, Margaret Cooper. And I had a wonderful chat with Margaret the other night, and I'm really looking forward to hearing your talk, Margaret. Welcome.
Thank you very much, Nona. I enjoyed our chat too, because it was the first time I had the opportunity to speak to somebody in a very similar situation to myself. Anyway, good morning, everyone. I hope you can all see and hear me clearly from my iPad in County Fermanagh. Let me know as we go along if you have any difficulties hearing me. I'll also, I hope you don't mind, be referring to my notes in case I forget to say something. I would like to thank Professor McMullin, Nona, Maz, and the team at MPN Voice for asking me to say a few words from my perspective as a patient who was diagnosed with AT quite a long time ago, 12 years in fact. My name's Margaret Cooper. I'm a retired solicitor and tribunal judge, and I'm married with 3 grown-up children and 7 grandchildren. So far, my story goes something like this. I was diagnosed, as I said, in 2010, after several routine blood tests showed that I had raised platelets. Nothing much to worry about, I thought, as I sat waiting to see Professor McMullin. Well, how wrong can you be? She explained to me that I had something called a JAK2 mutation in my bone marrow, that I had a myeloproliferative disorder called Essential Thrombocythemia, which was a form of blood cancer, and even worse, I needed to have a bone marrow biopsy. I didn't look forward to that, I can say, but in the end, it wasn't as bad as I thought. Due to my age, at the time I was 58, I was started on Hydrea immediately, a cytoreductive drug, which was a form of chemotherapy and again, quite scary, and also aspirin. Of course, the word cancer was very frightening, even though it was described to me as a chronic condition, but I'd never heard of ET, nor had I heard of anyone with it, and it was all a steep learning curve. Obviously, I was very worried. I asked myself all the questions that I'm sure most of you here today have asked. What does the future hold? What's the prognosis? How will I cope with, and how long will I be on the medication? On all these points, I did get some reassurance, but I was also worried, and this was really one of my main worries, could I pass the condition on to my children? Should they have blood tests? I was told that they were unlikely to inherit it and didn't need routine blood tests. At that time, Google was not a very helpful tool, and there were quite a few scare stories on the internet, so I decided to give that a miss. Of course, now times have changed and there is much more reliable information than there was back then. Anyway, I relied on advice from Professor McMullin. I took my Hydrea tablets and went for regular checkups. In the meantime, trying not to focus too much on what was wrong with my blood, and just waited for the appointment time to come round when I became a bit anxious and probably not too easy to live with. I know that many of you here today have been diagnosed like me for some time. I'm certainly speaking to Nona. I know she's actually been diagnosed for quite a much longer time than me. But now maybe you've attended quite a few of these meetings, and I've learned a lot over the years from the excellent speakers like this morning. I'm sure you will agree with me that it will be great when we can meet again in person and share our experiences over coffee, maybe something nice to eat, and a chat. But in the meantime, I hope you won't mind me repeating some thoughts that I have, which may be some use to people newer to this situation than myself. Now, I must stress to you that these are only my own ideas and may not suit others whose disease is different to mine. Firstly, I decided early on that I didn't want to be defined by ET, but rather it was going to be there alongside me. I would carry on my life as best I could, and I would seek help if I needed it. I decided that my way of coping was to tell a family and only a few friends that I had a blood disorder. I didn't focus on it being a cancer because I didn't want lots of chat and questions and difficulties. And I continued my work in my judicial role until I decided to retire in 2018, when looking after grandchildren called. For myself, as Nona said at the start, MPN Voice has been an excellent tool for information on all aspects of MPN. There are many articles about medications, living with the different conditions generally, lifestyle things, together with people's experiences that they have recorded. And there's also a buddy scheme, which I think is particularly valuable in the early days after diagnosis, as it gives you a chance to chat to somebody in a similar situation to yourself. So I would strongly recommend, if you haven't already looked at it, to have a look there for some answers. Through MPN Voice, there's also a grouping called Health Unlocked, which is an online forum with many contributors from around the world. This is monitored by Maz and the medical team, so misinformation is not allowed on it. And members of the group can maintain anonymity, but it is certainly a channel for information, chat, and friendship. And finally, there's also Facebook, Twitter, and quite recently, a very good Instagram page. Of course, most important of all is our relationship with our doctors. Here in Belfast, we are very lucky to have an excellent support team. One thing that I do when I go for my consultations is take a note of my blood readings. They're good to look back on to see what changes there have been. I also note down when I attend if maybe I haven't been feeling quite well, if I've had a cold or something like that. It really is my equivalent of a little black book, and it's also good to learn what the main terms for the readings mean. At the start, I think they're all a bit confusing. I know, as has been said in the previous talks, that many, if not most of us, suffer from fatigue. I find that it can vary from time to time, but it's always lurking in the background, and sometimes it stops us in our tracks. I don't want to give you advice, but I thought I would mention a couple of probably very obvious things that help me. You'll have heard them before. First of all, drink plenty of water, more than you want to. I find that it helps. Professor McMullen told me very early on to drink 3 litres a day. I was aghast, but I do try to get somewhere near that, and it definitely helps with fatigue. My second big thing is going out in the fresh air for a walk. Interestingly, I read in the paper a comment about President Biden falling asleep at COP26 last week. It said that a report had found that 15 to 20 minutes walk outside leaves people less fatigued and more energized. It certainly does that for me and for my old sleepy dog. So if you feel up to it, I would recommend it. Anyway, time has passed on. In recent years, my blood counts have gradually crept up. I'm now classified as having PV with both increased hematocrit and platelets. So my hydria has been upped, and I now need venesections from time to time. I've not found the venesections to be as difficult as I thought it would, and I certainly do feel better when I get rid of some of the thick, sticky blood. Probably I can't conclude a talk like this without mentioning the impact that the pandemic has had on all our lives, and as we've seen from the previous speakers. Being in the shielding group for a prolonged period of time was difficult for all of us with MPNs. For a long period, I was afraid to venture very far from home, didn't interact from anyone outside my household, except for the postman and the Tesco delivery man. How life changes. Anyway, Zoom has been a boon in this time. It's been marvelous to be able to meet up with all of you on Zoom from all around the world. And it certainly is a marvelous thing. Hopefully, with the help of the vaccines and now the booster, we will soon be able to lead a normal life in the not too distant future and meet up again. Finally, for me, I just wanted to mention the big question. How did I get this disease? So far, there doesn't seem to be any answers, although I know there's a lot of work going on, and I would encourage you to have a look at the Mosaic Study, which is starting up again soon, and it is looking for possible causes and ways to improve patients' quality of life. Nona's already mentioned it on MPN Voice. So in conclusion, for me, everyone's disease is personal to themselves. I've maybe not had as many symptoms as others, but I would just like to stress that we're all lucky to be here at a time when there's so much research going on for new possible treatments in the pipeline. I think that's well evidenced by the 2 speakers before me this morning. So my advice would be try and look after yourselves, maybe take a walk, but rest if you don't feel like it. And as Sir Winston Churchill used to say, keep buggering on, or more politely in our case, keep plodding on. Thank you for listening, and I hope I'll see you all in person the next time. Thank you.
Margaret, that was wonderful. Thank you so much. Your help and advice and your journey will, I'm sure, give a lot of people encouragement, particularly newly diagnosed patients. And I can't tell you how grateful we are for that. I'm delighted now to welcome Mary Frances McMullin, who is going to give us a talk on the MPN Trials. And I really look forward to hearing this, Mary Frances. Thank you.
Okay, thank you. Can you indicate that you can see that and that you can hear me okay?
Yes, we can.
Okay, so thank you very much for all the kind remarks today, and I welcome everybody from around the world, really. What I'm going to talk a little bit is trials in myeloproliferative neoplasms. And I do this because I think this is a subject I believe passionately in, but I want to just give a little bit of introduction on why we do clinical trials and why these are a good idea. It's always an idea to start with a definition. And this is a definition on clinical trials from the National Cancer Institute. So it is obviously from the National Cancer Institute, and cancer is their focus. But they state clinical trials are research studies that involve people. Each study tries to answer scientific questions and find better ways to prevent, diagnose, or treat cancer. And I think we take it broader than that, it's to treat disease. But there are certain issues that we think about when why we do clinical trials. First of all, the scientific evidence base can influence practice and advance knowledge. And I mean, that's really the main issue, that we want to know more about our diseases and what we can do about them. But they also bring about improved treatment and care for patients present and in the future. There's really a way to get safety and efficacy of new drugs. And certainly in our practice, it's a way often of getting new drugs to patients sooner. They also avoid ineffective treatments and avoidable costs. Looks at things, and if they don't work, then we shouldn't be taking them forward. It's often the basis for a drug license, and it's a health service requirement. But with participation in clinical trials, there are some things patients wish to consider, both positive and negative. So what are the positive effects? Well, one hopes for better health, prolonged life, access to the newest treatment offer, and monitoring and support. It's true that patients in trials often get extra monitoring and support from our trials nurses and others. And of course, it may help future patients. There may be negative effects. One of the biggest ones is that there is perhaps no control in the randomization. And this is always a big problem. People go into a trial wanting to get the new treatment, and they don't get the new treatment, they get the other treatment. The new treatment may not be better, but that is often the hope. Trials have to be monitored very carefully, so there are often extra tests, visits, and inconvenience. And of course, there's the unknown risk. Why are you doing the trial in the first place? You want to know more about whatever the treatment is, and there may be risks that we don't know about it, that is the trial. So it's not all positive. However, I believe passionately in trials as a way to advance our knowledge. And what I'm going to talk about in the next few slides is the trials that we have either have run or the program that we have coming in MPN. And I have to state that this is a Northern Ireland, this was primarily an MPN support meeting for Northern Ireland. So I'm focusing on very much on the pipeline that we would hope to be able to offer patients in Northern Ireland. But I start first with mention of the Mosaic Study, which has been mentioned before and is really a pivotal epidemiological study that we carried out in Northern Ireland and elsewhere, and which was completely supported by MPN Voice. And this original pilot study, which was to look into the epidemiology or the causes, the big question, why do people get an MPN? We had to do a pilot study to work out how we would do this first, and this was entirely supported by MPN Voice. And you can see we had 106 MPN patients and 127 controls, and the information from those patients will feed into the larger study. And this study, although it was testing methods, resulted, as you can see, in a large number of publications, which have increased the knowledge on MPN in general. However, it was actually a very successful study in that there was enough to actually analyze what we were looking at, what were there any factors associated with MPNs, and in fact we did come out with some information which will be of interest. So MPNs were developed more commonly and seem to be associated with obesity, but only in ET patients, with smoking in JAK2 positive cases, and with an increased number of CT scans across the board. But that's a difficult one because people have had CT scans for different reasons, and it may be part of the diagnostic process. And also CT scans, this is a sort of large amount of radiation as a CT scan, have changed over the years and how they were done. But still there was some information came out of this. So we have been very keen to move on to do a much larger study, and this has been referred to before. This has really been a difficult process, one getting the funding to get it up and running, and MPN Voice have been absolutely critical in this. And then also the COVID has held things up to a large extent. However, we've started this and we are opening this right across the UK and getting sites in Ireland. So hopefully over the next few months, many people, particularly those, I have to say, who are most recently diagnosed with their MPN, will be recruited into this study. And this study will evaluate lifestyle factors, medical risk factors, occupation, quality of life. And you can see on the diagram on the right, the previous one, where we were able to look at the quality of life in our MPN patients and see that they had a lot more symptomatology than age, sex matched controls. We will also build up a big bank of samples, blood, saliva and toenails, and we'll be able to use these as we move forward. And we will have these on both the patients and the controls. So we'll be able to do a very large, by far the largest in the world, epidemiological study in Mosaic, in MPN. So that is coming imminently. Other studies then in Polycythemia Vera and ET. So one that has been published already is the MAGIC study, which was an investigator-led study published in ET and presented in PV. And what this was looking at patients who were hydroxycarbamide resistant or intolerant, who were then randomized between ruxolitinib or best available therapy. And you can see that the patients on ruxolitinib had a much better probability of having a CR, a complete remission, or a partial remission than on best available therapy. And there's many more results coming out of this study suggesting favorable things for ruxolitinib. So we want to go on and do further studies in Polycythemia Vera. If ruxolitinib is good in the hydroxycarbamide resistant or intolerant, then should we be looking at it as first-line therapy in Polycythemia Vera? And that is exactly what the Mithridate study is opening. It isn't yet opened in Belfast, but it will be soon opened in other centres, is going to do. It's always like this, but Mithridate, all our studies start with M, but Mithridate was the antidote for poisoning created by Mithridate is the sixth. So that's why the study's been called round that. This is a very important question, which again is investigator-led, which is really very useful type of study to do, because investigator-led studies, we control what happens, we keep the patients on the therapy for the period of the study, and we get very interesting and verifiable results. That's the trial design for that study, and it will be recruiting 586 patients in the UK and France, and will run for 4 years. And it's looking for patients over 18 with PV who have been on cytoreductive therapy for less than 5 years. So another drug which is also coming for PV studies I want to mention briefly is Juvenile Stat. It's a histone deacetylase inhibitor. It has been used in various conditions, but it has been used in some preliminary studies in PV, and has shown some very useful responses. So the company who run that are going to run another study of this, again comparing it to hydroxycarbamide. It will be called Give in PV, and hopefully that study will open in later on in 2022. So the idea is that then we will have mithridate for patients with PV, and then following on from that, the given PV study. But what about myelofibrosis? Well, myelofibrosis, of course, is the area where, if we talk about unmet needs, there is a huge unmet need. These patients have ruxolitinib, which has certainly changed treatment, but it doesn't work forever, and it doesn't work in some patients. So this is the area where people are looking particularly at bringing in new agents to look at these patients. And our aim would be to have a sort of pipeline that we go from one trial to the next. Many of these trials only refer to few patients and then they move on, so that we always have something running for patients with myelofibrosis. So just to give you a little flavour of the things that we've had recently and are coming in the future, this is the idea. You can see on this the JAK-STAT pathway, where ruxolitinib interferes and blocks this pathway, but then downstream there are other pathways. And the idea is to check new agents that may interfere in this pathway and see would they be beneficial in treating myelofibrosis, either on their own or in combination and at different points in the pathway. So one of the drugs that we're interested in here is a thing called BET, which is one of the downstream genes and proteins. And if we could get compounds that would inhibit this BET protein, then that may be useful. And there are a number of these being tested at present. First of all, the MANIFEST trial, which is really just coming to a close, which is looking at patients with a drug called CPI-0610, which is a BET inhibitor. And this has been given to patients in various means, including with ruxolitinib or as an add-on. And you can see this shows some of the early results. These are patients whose spleens are shrinking, getting improvements in their symptom response, and overall getting improvements, including in some of these patients, conversion from transfusion dependence to transfusion independence. So that trial's nearly done. The next one that's just running at the moment is an Abv trial, which is looking again at a combination of ruxolitinib plus another drug called navitoclax. And again, this is looking at lots of things, the things you want to know, the spleen volume, but also looking at the symptom score, bone marrow fibrosis, anemia, etc. So that trial is up and running at present, and we have patients in it. The next one that's coming is again an investigator-led one with a different new BET inhibitor, this drug PLX2853. And the idea would be that we would have this open as a useful route for patients once we finish the ones that we've had already. I would point out in this some of the entry criteria, and this is a problem because these trials test patients basically with good blood counts. Most of them need a platelet count over 75. And of course, many of the patients with the more advanced disease aren't eligible because their platelets are lower than 75. But I suppose this is the way of the world that we test these new agents in a group of patients who are likely to be able to tolerate them at starters. The final myelofibrosis study I want to mention, because I'm very excited about it, is that we've got funding to run a combination study in newly diagnosed patients with myelofibrosis using fedratinib, sort of son of ruxolitinib, but in combination with a new drug that has been licensed for the treatment of Polycythemia Vera, interferon, ROPEG interferon. And the idea with this is if the tyrosine kinase inhibitors, the fedratinib and ruxolitinib, work well, if we added something else, would that have greater effect on what we're really looking for and getting rid of the disease? So this study will start soon for a small number of patients because we have to look at safety and efficacy before we go any further. So at that point, of course, everybody says, what about essential thrombocythemia? There have been some very successful trials in essential thrombocythemia, starting with the PT1 studies, which have been the biggest studies in the world. There's not much at the moment, but I just put this up that the MANIFEST trial is about to open another arm with the BET inhibitor looking at this in patients with essential thrombocythemia, again, who are resistant or intolerant of hydroxycarbamide or hydroxyurea. So that is something coming for essential thrombocythemia, but it's fair to say that at the moment, the main focus is on myelofibrosis trials. So just in conclusion, trials advance scientific evidence, get new treatments to patients and sooner, and build up a sample bank, which is very important for further study. The current trials in progress and opening in Polycythemia Vera. I hope I've shown you we aim to have a pipeline of trials in myelofibrosis. Hopefully there will be further essential thrombocythemia trials in the future. So thank you very much. I'm sorry I've gone on too long.
Thank you very much, Mary Frances. It certainly wasn't too long. I'm completely overawed by the number of trials that are going on. It's amazing, and it's really reassuring for the patient community to know that all these things are happening. And I'm sure in time we'll get the results on the website and updates on the website. So as I said earlier, keep looking at the website on the research page. Now I'm delighted to welcome Louise Gribben, who is an advanced nurse practitioner at Craigavon Area Hospital. And Louise, I'm really looking forward to hearing you talking about what to expect and managing symptoms, physical, and actually most importantly also emotionally, because I never underestimate the impact of the diagnosis, not only on the patient, but more importantly on the family as well. Welcome, Louise.
Thank you, Nona. Good morning, everybody. Hopefully you can hear me okay and see me. Well, maybe not see me. My name is Louise Gribben, and I am a haematology advanced nurse practitioner in the Southern Trust in Northern Ireland. My presentation, as Nuna has said, is a practical presentation to look at some of the sort of common concerns and issues and symptoms expressed by our MPN patients. But bear in mind that not everybody experiences the same symptoms as each other. But so it is important for you to discuss anything you're concerned about really with your treating team at your appointments when you come. So these appointments currently, why is my slide not moving? There. These appointments currently in the current climate may be face-to-face or more often now at the minute via telephone consultation. So I mean, our clinic appointments are 10 to 15 minutes long, and during these appointments we hope to look at your blood counts, reassure you, look at sort of new or persisting symptoms, organise a new script, a new appointment date, discuss your concerns and issues, any questions you may have around your medication, various risks. Can you go on holidays? What about vaccines? Or really discuss your condition again. And those are quite a lot of things to cover when you have your 10 or 15 minute slot. So it is important that you're prepared for your appointment really. Read any information that we've given you beforehand regarding your condition and the treatment. You can contact your clinical nurse specialist prior to your appointment if needs be. And lots of our patients find that actually writing down their questions and concerns before they come to clinic is very helpful, because when you're sitting in front of the doctor or the practitioner, these questions go out of your head. So having them written down is good, and bring someone with you. Another set of ears, if you're allowed in the current climate, is always invaluable. I'm going to have a wee chat really about some of the concerns that most patients will discuss with us. You know, we really have heard anything you can tell us, we've heard it before, so don't be afraid to ask us. There are sort of the four, I've bracketed them into 4 areas there: physical, emotional, social, and financial. And I'm going to briefly discuss some of these areas. As I say, please be mindful that not all patients who are diagnosed with an MPN will experience, you know, any of these or all of them. The biggest one on the physical end, as Allister has said and Margaret has said, is the fatigue, probably the most common side effect of all the MPN groups, and a very difficult one to manage for some patients. What is fatigue, and you will be able to tell me this better because you're going through it. It's this unusual and persistent tiredness, really stops you at times from functioning normally. it isn't relieved by rest or sleep, and really can be overwhelming at times, and not really related to anything that you've done. So it's not because you've run a marathon. It is very individual to each person, and it's particularly relevant in patients with blood disorders. So please, you know, look up the supporting resources that are there about how to cope with fatigue. Sleep and sleep hygiene and good sleep hygiene is the best tips that some of our patients will say. MPN website has a lot of tips here. Use labor-saving devices. You know, don't do things that you don't need to do. Don't feel guilty about delegating, which is always joyful. Try and do a bit of exercise. As Margaret has said, a 10 to 15 minute walk really refreshes you. Try and relax, try and eat well, all of the things, and drink water, as Margaret has said. And keeping a diary of fatigue is sometimes very useful, especially when you come for your appointment. It can give you a guide as to sort of the extent of your fatigue, gives your treating team a guide to the extent of your fatigue, and we can monitor it and see, is it related to medication dosing or certain activities that you have done, or your blood counts even, and this will help in our consultations. So moving on then to itch. Itch, for those of you who suffer from it, is a particularly troublesome symptom that's sometimes very, very difficult to treat. You know, water-induced itch, as my previous speakers have said, is particularly severe, and even a sweat will promote itching. And the itching can be anything from severe itching, as you can see, burning, prickling, stinging, contact with any type of water, bath, shower, and they'd say the arms, legs and trunks are usually the worst. Some patients will find, if they've got a high hematocrit, that the itch is relieved when we do a venesection. Other patients, unfortunately, who have itch with ET, for example, you know, no matter what, even treating the platelet counting, and the itch continues, and it's very difficult to manage. Antihistamines do occasionally help, but it is trial and error really to find one that works. There's a few bits of advice here, well, a lot of advice there really about itch. I mean, one patient has said to me the water wipes was her savior. She uses those more often than showering or bathing. And as Margaret has said, drinking lots of water, 3 litres if you're allowed to drink 3 litres of water. So you can read through those lists yourselves. Sun apparently helps, not that we see much of it here, but in some of those other lovely countries that you live in, you may find that helpful. But I say it can be a troublesome symptom to manage. Headaches and pains, as some of the previous speakers have related to, is variable for patients. Some patients have no headaches or aches and pains. People might complain of fuzzy or foggy heads, which is particular in patients with PV with high hematocrits. And again, that is usually relieved by a venesection. They feel much clearer. And in fact, patients will tell us they need a venesection before we even see their blood results. Some of the headaches and pain can be caused by the medication itself. Interferon, we know, can cause aches and pains and flu-like symptoms. And we'll mention that in a wee minute. Many of patients with fibrosis, myelofibrosis, will report some bone pain, and it's important to report that to your treating physicians. And as I say, ET patients can have sort of burning in their hands and feet. So again, all of those things are important to report, and we can help as best we can. Moving on to some sort of dietary and weight issues. More often in myelofibrosis, these symptoms would happen where patients feel full earlier. They can't eat a full meal that they would normally eat. Some nausea and weight loss, mostly related to maybe the spleen enlarging and you not being able to eat your full meals. It would be important to eat regular small meals, and that will ensure you get enough calories in. And just like fatigue, keeping a food diary might be useful. Occasionally you will be asked to go for an ultrasound to measure the size of your spleen, to monitor its size, to see if it is the cause of you having these symptoms. And of course, we can refer you to a dietitian if we feel it's appropriate. In some patients, it's actually the treatments that cause the side effects. Interferon in particular, certainly at the beginning of its use, can cause what patients would describe as flu-like symptoms, aches, pains, chills and shivers, we recommend if you take your interferon at night and take paracetamol about an hour beforehand, that tends to lessen the symptoms, and plus you're sleeping through them basically, so they don't affect your day-to-day life as much. And also, now that interferon is pegulated, it is given on a weekly or fortnightly basis as opposed to the original 3 times a week, so much easier to manage. The hydroxycarbamide tablets can sometimes make patients feel a bit nauseated or sleepy, and we advise them to take it at bed. Again, they sleep through those side effects. There are lots of useful resources that your clinical nurse specialist will signpost you to try and help with side effects of treatment, and they're free at all your local cancer centres and Mcmullen centres, acupuncture and aromatherapy and all those lovely things. Please make use of them, and if you want your clinical nurse specialist to refer you, that's fine, but I think you can self-refer also. Work, I suppose, is having flexibility with patients, certainly when you're newly diagnosed, is important. And it's important for your employer to know that your condition is protected under the Disability Discrimination Act. So they have to put moderations in place to help you manage your workload. There's a few wee tips there in that PowerPoint to say, changing your hours if needs be, being for your employer to be a bit more flexible, working from home at times, which a lot of us are doing now. Asking for help is important. Let your employer know that you're struggling if you are. Negotiate for breaks. And ask for help. Delegate as the previous, if you're able to someone else, some of the jobs that are more demanding. There's a little bit on our Mcmullen website about work support, and you can refer to that and refer your employer to that if needs be. But as I say, use those support networks that are in place. Margaret's already referred to the emotional uncertainty when you get a diagnosis of MPN, and uncertainty about the future is top there. And I suppose it's being diagnosed with any chronic condition. You're worried about what the future holds. What treatment am I going to take? Will it work? What are the symptoms going to be? What are the side effects going to be? And you do have a sense of you've lost a bit of control, because you're relying on your medical team to advise you and direct you. And we do like to involve you, as Allister indicated at the start. We have this relationship with our patients where we are very open about treatment options, and we like our patients to be involved, and we like our patients to look into the research and ask the questions and prepare for their clinic appointments. And it's obviously all of these concerns can affect your mood, leading to some sort of psychological depression in some cases. So lots of patients will need emotional support throughout their diagnosis, and please, be aware that there is lots of help out there, lots of voluntary organisations that will help, and let your clinical nurse specialist and your team know. Again, we can refer you, as you can see in the slide there's buddy systems, psychology input. Mcmullen will help. There's Action Cancer Focus, and there will be your local support groups as well. So always ask for help if you need it. There's another local, this is more local to Northern Ireland. It's a great voluntary organisation that we use quite often for our patients, and they provide a wide range of therapies, including massage, relaxation, reflexology, counselling, and you can take a friend with you who can also avail of some of the services that they provide, which the patient's relatives love. Social, a lot of our new patients when they're diagnosed will say, can I still live a normal life? Can I still do the things that I normally do? We sort of recommend alcohol in moderation, just because your liver has to process usually additional medication that you're taking. I mean, it's no smoking. It would be for any person, regardless of an MPN. Traveling, yes, of course you can travel. You might need a letter to cover your medication if it's injections, but cover up in the sun. Be careful with your skin. You are at a greater risk of skin cancer, so use a high factor. Even in our Northern Ireland weather, we would recommend our patients wear sun protection, particularly in their faces and heads if they don't have much hair to cover. And always check the Mcmullen website for your best insurances. Sometimes travel insurance companies can take advantage, but the Mcmullen website have lots of resources for the best deals to get you on your holidays if we're ever allowed to go. Financial worries, of course, are there. People think, can I continue to work? And in most cases you can. continue to live a normal life. MPN patients have the same rights as anyone else with a cancer diagnosis. So there is a citizens advice that Mcmullen provide, where they provide financial support. And as I say, ask for that. Your CNS will refer you to them, or you can refer yourself. And Mcmullen support, work support assistance will help you with adjustments to your working day, time off for hospital appointments, which you're entitled to. And again, getting the support of your employer is very important. We really want you to ask questions. You know, as I said before, write your questions down. Come with pre-prepared questions, because those are the things that are keeping you awake at night. We want to know about it. Use your websites. Your MPN Voice website is an invaluable resource for patients, and attend the patient days when we're able to get them back up and going. Really, in summary, you know, we know that some patients will have side effects. Not all patients will, but tell us about them if you have them. If you need help, ask us. If we can't help you, we refer you to someone who can. And as I said, come prepared for your appointment with your questions written down. And finally, you can always make an appointment with your clinical nurse specialist outside of your clinic appointment if you need to discuss really any further issues. Even if it's on the telephone, you will have a contact number for her and they or him, and they are invaluable points of resource for you moving on. And thank you very much for listening. Hope you could hear me.
Thank you very much, Louise. And again, I'm sure people will get a lot of help from everything you've said. I am mindful for everybody around the world that every health system is different, and we here are incredibly lucky with the signposting that we can get in the UK. And hopefully, you know, I'm sure it is, but it is just different. But thank you, it was so helpful, and particularly the emotional side, really, really helpful. We now come to what is usually a quite exciting time of the forum, and I'm sure you will all agree we've had some amazing talks this morning. And I'm going to hand over to Mary Frances, who is going to chair the Q&A and the panel questions. What I do need to remind everybody is the panel won't be able to answer any personalized treatment plans. But over to you, Mary Frances.
Hello, Nona. Hello, everyone. So we're going to have a question and answer session now. It's my job, I think, to bounce questions round to other members of the panel. Would please ask questions into the chat. There's one at the moment, which I'm going to start with. I also have a list of questions that were submitted in advance, which I will bounce around a bit. Some of them are personalized, so I'll try, if I can, to sort of change them to take the sort of to a more general thing, but I may leave out some of them if they just seem to be a sort of particular question that's, you know, we want a question about somebody's individual management, because we can't do that. So if we start with the first question in the chat, I'm a bit confused about taking aspirin for ET. Is it UK policy that all patients with aspirin, with ET, take aspirin? That is, if they can tolerate it. I think the general answer is yes, but if Allister's on, maybe he would address that.
Yes, hello, can you hear me?
Yep. Yes.
Yeah, brilliant. Yes, very good question. So broadly, the answer is yes, that there's clear evidence that aspirin reduces cardiovascular complications in essential thrombocythemia. There are a number of variances and caveats, which I mentioned in my presentation, which is some people may be on antiplatelet or anti-clotting drugs, such as warfarin or apixaban or clopidogrel already, because other conditions or other previous clots dictate that they're already on those drugs. And some patients may continue those instead of aspirin. The one nuance which I mentioned in my talk, which is emerging in some of the data, is in relation to those people that have CALR or calreticulin as the mutation which drives their condition. There's some evidence that shows that patients with calreticulin mutated essential thrombocythemia have a relatively lower clot risk than those people with the JAK2 mutation, and perhaps a slightly increased bleeding risk compared to those patients with JAK2 mutated ET that are on aspirin. But largely speaking, my practice, and those of many of my colleagues, is if aspirin is tolerated, patients continue on it. There will be individual cases where that will be discussed, and there's a balance of benefit and risk to be had on an individual basis with your clinician. But broadly speaking, the answer is yes, that aspirin, where tolerated, provides a clear benefit.
Okay, so I think we'll go next to a question about flying, because this has come up. This has actually come up in the submitted questions as well. And Louise, you mentioned this. So what advice about flying, given as the risk of clots is elevated, can you fly? Well, we'll say yes to that, but can you give a wee bit more information, Louise, because this seems to be an issue coming up?
Yeah, I mean, we would advise our patients that they can fly, as Mary Frances has said. I suppose with any person flying long haul flights, I suppose, carry increased risk, and we would always encourage our patients to drink plenty of water during the flight and before the flight. Try and avoid alcohol as much as you can, and move about on the plane. Sort of if it's a long haul flight, go for regular walks, move your legs, move your feet when you're sitting there, and try to keep active during the flight. But certainly, we never advise a patient not to fly once their disease is managed and controlled. The only problem with the flying bit is maybe taking your interferon, so you may need a doctor's letter to carry your injections with you through security and so on, but that's very doable. Anything else I've missed, Mary Frances?
No, that's fine. Yeah.
One thing that I must say I advise my patients to do is to try and secure an aisle seat somehow. It used to be, you have to pre-book these things nowadays, but it used to be that it was first in, first served sort of thing. There was a very large study which looked at people flying through Charles de Gaulle Airport, many thousands of patients that looked at clot risk, and clot risk seemed to be significantly lower in those people that secured an aisle seat. Possibly because you're always moving your legs, you don't get hit by the drinks trolley. And secondly, the two people on the inside of you will be inevitably looking to go to the bathroom all the time. So you'll be up and down. So it just promotes being able to move around. And what we're keen to avoid is people, cramped in a window seat and not moving for 10 hours.
Yeah, good point. Okay, there's a question that's just come up about ibuprofen when on aspirin, which is, I have to say, is an interesting question. Taking them, is it right that you can't take ibuprofen when on aspirin? Now, this is an issue because they both interfere with coagulation in a sort of very general term, but it is low dose aspirin. So unless, I don't think I would be telling people that unless they had particularly abdominal pain or problems with them, when they probably need to be avoiding the aspirin anyway. Allister, what would you specifically tell people to avoid ibuprofen?
No, I think I wouldn't. I would agree. I would say that the dose of aspirin we use is a low dose, considering the therapeutic doses that people used to use when aspirin was used primarily for analgesia. But what I would say is that ibuprofen, I would recommend avoidance of long-term use of ibuprofen, regular use without medical advice. So occasional ibuprofen, I think, is permissible on low-dose aspirin as long as you don't have a history of stomach ulcers or getting abdominal discomfort. But where you're requiring regular ibuprofen, you should be seeking medical advice.
Do you need to tell your travel insurance or your life insurance about your ET diagnosis? I think the simple answer to that is yes, because if you fall over and break your leg when you're away on holiday and you haven't told them, they'll find a reason not to cover you. I'll come back to this and try and switch between them, but I'm going to switch to some of the submitted questions. And I'm going to start, Patrick will be glad to hear, with the COVID and vaccination. And I thought there would be quite a lot of this actually. But Patrick obviously explained it very well. But the first question is that somebody, or well, I put it generally, a person's having a severe reaction to the second Pfizer jab, and this sounds reasonable, with myocarditis and pericarditis, and worried about getting a booster from the same vaccine. So what about the mix and match, and can you change, and can you insist that you get a different one as a booster? I think that's a reasonable question.
Yeah. So the side effect profile seems to be quite different between the different types of vaccines. If you broadly divide them into the mRNA vaccines, which is the Pfizer and the Moderna, and the non-mRNA, which is the Oxford vaccine mostly. And the specific side effects that occur with the Pfizer vaccine seem to be things like, which I have to stress are very, very, very rare, but they have been reported, things like myocarditis, whereas with the Oxford vaccine, very rarely people can report these vaccine-induced thrombosis and thrombocytopenia episodes, but although we didn't pick up any increased risk of that in our study looking into this. So I think the advice would be to consider getting an alternative vaccine, but what I would do before that is see if you could have an antibody test to see what your response has been. I think this specific question had mentioned they'd already had 2 doses. So that's quite a good, regime already. So I would be looking to get an antibody test to see what the response had been. I certainly wouldn't re-expose myself or my patient to another mRNA vaccine, which is the Pfizer or Moderna. And I would think about giving an alternative vaccine if there was not a significant response. The other thing to mention is that in patients who haven't had a response, there is becoming more and more availability of monoclonal antibody treatments, which can be used in patients as an alternative to vaccination. And that's something I'm looking into for a few of my patients. There's a drug called Ronapreve, which is a combination of 2 different antibodies, which replaces the antibodies that aren't formed by patients. So that's something that is another option as well. The Oxford vaccine risk, there hasn't been reported cases of the myocarditis as far as I'm aware with the Oxford vaccine. So that would be an option. Okay,
thank you. I have another question here. I think you've really covered it, but because I think it needs a bit of clarification in getting the information out there, I'm going to read out the question and you can sort of see what you can do with it. So what is it about ET and PV and the treatments for them that causes COVID to be more severe for patients and causes vaccines to be less effective? What underlying processes are involved? So that's all about the immune system.
Firstly, I would say that we don't have strong data to say that the response to vaccine is worse in patients. We do have some data to suggest that infection outcomes were worse. But again, we have to look at those caveats that I mentioned about the bias that's introduced in those studies, where lots of people would have COVID infection that their treating physicians wouldn't know about, so they wouldn't show up on those studies. So we have to be very careful in over interpreting the risk associated with COVID from those studies. So I wouldn't say that there's very strong information yet to say that people, particularly with ET and PV, have increased risk from COVID infection. We need to wait for more studies to come out before we can say that. And we know, as mentioned in my talk, that the immune system can be affected in myeloproliferative neoplasms, but it's extremely variable. And what we see is it's typically more the case in patients with myelofibrosis, and particularly when the myelofibrosis is at a more advanced stage. And what we know is that what we see in myelofibrosis is that there is what we call a pro-inflammatory state. So this is the abnormal cells in the bone marrow, which are causing the disease and causing the fibrosis in the bone marrow and the splenomegaly. They secrete lots of cytokines, which are these chemical messengers that cause lots of processes in our body. And there's aberrant, incorrect production of these cytokines, which causes inflammation throughout the body. And what happens is that inflammation is non-specific, and that actually causes a weakening of the immune system. So that's relating to the disease itself. because there's this non-specific inflammation that actually weakens the normal effect of the immune system at being able to respond to infections. But that's really particularly related to myelofibrosis, to an extent other conditions, but more so myelofibrosis. And it's these cytokines that are responsible for most of the symptoms that we see in MPN patients. And that's why ruxolitinib, which is a JAK inhibitor, is so effective at controlling symptoms in MPN. So and that brings me on to the next part, which are the treatments. The treatments, particularly things like myelofibrosis, which is a targeted tyrosine kinase inhibitor, which controls JAK-STAT signaling, inhibits JAK-STAT signaling, I should say. And as mentioned, JAK-STAT signaling is responsible for multiple processes in the immune system. So through inhibition of that, although you're relieving many of the symptoms associated with the high cytokines, you're actually weakening the immune response. So that's why that particular treatment is concerning. And we do see increased infections in our patients on ruxolitinib particularly. The other treatments less so. Pegylated interferon I wouldn't say is immunosuppressive. If anything, it's the opposite. It's an immunostimulatory drug. And I don't think there's evidence to suggest that that would particularly weaken the immune system. Hydroxycarbamide is kind of a non-specific cytoreductive agent, which can be immunosuppressive, but I wouldn't say it's overly immunosuppressive, particularly if blood count is being monitored and it's confirmed that the white blood cell count is within normal range, then I wouldn't be too worried about my patients on hydroxycarbamide at this point in time. Okay, thank you. That, of course, is just some more questions on COVID in the chat. One is common RT Pfizer. I saw this when I went for my booster. So you give me something different. And it's actually the Pfizer vaccine, as far as I'm aware, as they suggest. It's just the name for it, but it is quite confusing because you have to look to find the Pfizer on the leaflet they give out. Other question there, just above that, is somebody who has refused Pfizer due to allergies or had an Oxford due to stroke, wants the Moderna one, and how do they get that? Patrick, I don't know where you can I think you can request different ones. Yeah, I think if you've got specific, what we would say, contraindications to the other vaccines, then you should be hopefully able to request an alternative one. Yeah, so I think that would be the best thing to do, to discuss it with your vaccine centre, if they can request the specific. I mean, the bottom line is get vaccinated if at all possible. Yeah. Okay.
Sorry, can I just add? I think some pharmacies in Northern Ireland are giving out the Moderna here, but they would need to, on an individual basis, I would recommend people discuss with their general practitioner or the haematologist, because my understanding, Patrick, is that the booster Moderna dose and the third primary Moderna dose are different.
Correct. Yeah.
So if people are considering or going for the Moderna vaccine, just make sure you discuss it with a physician first to make sure that you're allocated the correct dosage.
Yeah, the Moderna dose for the booster is a half dose as opposed to a full dose for the third dose, which isn't the case for Pfizer. So that's the only difference. I mean, if you ended up getting a half dose for Moderna, I don't think that would be the end of the world. The dosing is still to be established as what's effective. And actually, I was reading that the amount of mRNA that's put into the Moderna vaccine is actually significantly higher than the Pfizer vaccine. So it could be, and there is some early studies to suggest that in the healthy control population that the Moderna may actually be slightly more effective than the Pfizer vaccine in terms of antibody response. But the bottom line is just try and get a vaccine, as Prof mentioned.
Okay, so switch a little bit. Louise, there's a question, quite a long question about diet. Any consensus on diet? Are there any recommendations? They're talking about vitamin K, but of course that's an issue when people are on warfarin. Are there any supplements one should take or avoid? Louise, what dietary advice do you give to people? Not easy question.
I probably need to give it to myself too. I mean, you know, it's the same for the population as a whole, I suppose. If you eat, you know, balanced diet, fruit and veg, all the things that we're supposed to, you shouldn't need additional vitamins on top of that. We tend not to. I mean, there are some medications that we use in our practice that we we ask our patients to avoid certain foods, but I'm not aware of any that we ask our patients to avoid in PV or ET. That I can think of. Sure, there's not. No, but I mean, you know, drinking plenty of water, as Margaret said, 3 litres, if you can, and fruit, veg, and just a little bit of what you like won't do you any harm.
Yeah, I think the other thing to say is what we say to patients in general. If you eat a good diet with plenty of fruit and vegetables, you should get all you need. Lots of supplements are sold. They're a good way of parting with your money. And this is not really MPN advice, it's in general. We as doctors don't have the same control as to what's in supplements and what's sold over the counter as in medicines. So there's always a worry that there'd be something in them that might interact with your medication. So in general, caution, and you say you shouldn't need any supplements if you eat a good balanced diet. Certainly that's the advice that I would give in general.
And we had a patient many years ago who was unbeknownst to us, that was taking some sort of vitamin or some sort of supplement, and actually it was hindering their absorption of their hydroxycarbamide, and we didn't understand why his platelets weren't coming down, and turned out there was something charcoal based in the vitamins which we didn't know about. So always tell your treating team if you are planning to take any additional vitamins beforehand.
Patrick, were you going to add something?
Just a quick comment to add, to be cautious around taking anything that contains extra iron, particularly in our PV patients. That's, you know, could increase the thrombotic risk in that group if it drives an increase in red cell production further.
Yeah, good point. Okay, so there's a number of questions about the JAK2 mutation and the risk of clotting, and evidence for that. And then some people are asking, is there anything to do with the level of the JAK2, the amount of the mutation, and the risk of clotting? Allister, would you like to elaborate a bit more on what we don't know, perhaps?
Yes, which is quite a considerable amount within the scientific MPN community. So the JAK2 mutation is associated with an increased clot or thrombotic risk, and that is beyond dispute. It also, the mutation has a potential to induce clots at what we would call unusual sites. So sites not normally like, you know, a DVT in the leg, but for instance, clots in the tummy, or rarely and quite severely clots in the head. We know that JAK2 itself is associated with high clot risk, irrespective of the blood counts as well, because quite a considerable percentage of people that have a clot in their tummy, often up to as much as a quarter of people, will have normal blood counts at the time of the clot in the presence of a JAK2 mutation. Now, added into that, if the blood counts are high, then what we'll try and do is reduce the risk back down. But that is why we do not stop aspirin or anything like that once the blood counts are normalized. The aspirin is there in the background, or if you've had a previous clot, you will be on generally a different product, a different blood thinner, such as warfarin or apixaban, or one of the similar newer agents. The level of the JAK2 mutation, or what we'd call the allele burden, is a much more tricky question and is still under considerable investigation. If we look at a different condition, chronic myeloid leukemia, where we use a tyrosine kinase inhibitor, we can reduce the levels of the abnormal mutation in that condition down to a fraction of a percentage. It is a very, very effective medication for that condition. Ruxolitinib does not induce levels of reduction in JAK2 to that level. So even despite use of ruxolitinib, the JAK2 burden or the JAK2 mutation is still there. Some reduction in that has not necessarily clearly, whichever product you use resulted in a decreased clot risk. So there's still a lot of work to be done on that. Another drug that we use commonly, which is interferon, can reduce the JAK2 burden or the JAK2 level in around a fifth of patients. But again, it is unknown at the minute how well that correlates with reduced thrombotic risk. So the ongoing message would be that even if your blood counts are normal and you're on aspirin, the aspirin generally continues unless there's a different reason to stop it or to change it that your doctor or treating team will advise you on.
Okay, so I'm going to read out a question from the chat, which I think is quite important, and then attempt to answer it. But I invite my colleagues to jump in if I think I haven't explained it properly. So the question is, does the expert recommend testing for the JAK2 gene in children? And if so, from what she or he says, can this be done discreetly? Now, I think this question is about inheritance of myeloproliferative neoplasms and the risk of children inheriting it. There is when somebody has a myeloproliferative neoplasm, there are some families where it seems to be slightly more likely, but it is a very small, that other people will get an MPN, but it's a very small increase. And it's sort of, if you look at the population in general, if somebody has a particular family genetic type, they may be twice as likely to get an MPN in the same family as other members as compared to the general population. Now, twice as likely is very low because these are rare diseases. So it's not justified to test in families before somebody presents with symptoms or questions of disease. And that's what we would say in general. Just because somebody has this, we shouldn't be testing other family members unless there's some issue that they need to see. So we don't recommend testing other family members unless there's some clinical indication to do that. The other question is, which is why I raised this, how can this be done discreetly? So you cannot test a child for a genetic and this is an acquired genetic disorder, but look for it before the age of consent. It's not a question of doing it discreetly, and you cannot do that unless they were presenting with a clinical picture where you had reason to look for that. So you can't do that now. Obviously, once we would usually say if people do want to look, you want to wait till people can consent themselves. That the age at which that is varies. But the important point is that you would not go and test a child with no symptoms or signs for something in case they might have inherited it. Would my colleagues agree with that? Yep. Just think that's an important point. Right, what else have we got? Somebody's wanting to know, can they take herbal teas? We put them off everything because of our dietary advice. Louise, what do you tell people? Can they have their nice herbal teas that they've been taking for a long time while on interferon and aspirin?
Well, I imagine so. As I say, it's and any medication that we want to check, we usually ask our pharmacy physicians to do an in-depth study on the ingredients, and they come back to us. But I've never heard of herbal teas being turned down to my knowledge, but
no.
There may be one in the future, but at the minute, no, it should be okay.
I mean, I think there's a fair point that we all assume that our patients take lots of things that we don't know about and have been doing for many, many years. And that's not to do with MPN, that's in general. There's a question here about interferon, which also comes up in some of the online or the submitted questions, about the question of interferon and preventing progression. And also, given that there's some evidence that pegylated interferon may induce molecular remission, where this should go. And there's a question in the chat again, which I think it sort of fits into that if it induces molecular remission, would you be better looking at pegylated interferon sooner rather than later? Now, this is a subject of debate, and I think it's an area where things will evolve. First of all, in PV, and we looked at all the evidence, we've now got to the point where hydroxycarbamide or pegylated interferon are first-line treatment, and it's really a question and a decision, you know, not one isn't better than the other, and it's a decision to be made between the clinician and the patient, which one they go for first. That's not the case on the guidelines with ET, but I think in practice it's actually moving in that direction more and more. That either of these agents is effective, so it's not necessarily that pegylated interferon is second line. But I think that the really important question is the people who we say are low risk and we don't treat, would it be better to treat them earlier and see if you could remove the clone at an earlier point before they get to progression? And I think that is the subject for debate, which will carry on more and more. There is a low PV study which has just been published by the Italians, which shows that if you treat people with low risk PV with pegylated interferon, it's the Ropeg interferon, it's pegylated interferon, as well as venesection, that they have a better outcome. Now that's the first study that's been done in that area. It also shows that there's some reduction in the clone size in the treated patients. So it may be in the future, we need a bit more evidence, but I think things will move in the direction that is being suggested. But it's a question of getting good agents that are proven to be more beneficial, that can be tolerated over very long periods of time. Again, Allister, Patrick, would you agree with that or disagree?
Yeah, I would agree. I think it's a very interesting area for debate, and it's something, there's some interesting data coming through on Ropeg interferon, which I think I've seen this morning has actually just received FDA approval in the States. So that's another drug that's going to start coming through, and it's very exciting to have another option. Just one thing I would add is something that we're doing in our clinic in London is actually probably using interferon as a first-line therapy, particularly in our younger patients who have many years of disease burden ahead of them. And the main rationale behind that is aiming for some kind of molecular response and disease modification in that sense. So,
I think we're all sort of moving in that direction. As I say, we started out that you only give interferon to young, and the definition of young was under 40 in the previous guidelines. As I say, it's moved up all the time. And the evidence shows that even older people, and what are older gets older and older all the time, looking at it, can tolerate it well. And as I say, it is I think Allister's probably agree, we sit in the CMMDT, we very much offer pegylated interferon now up front. But I do make the point that hydroxycarbamide is actually a very good and well tolerated drug. And if you go back to the original Cortelatio study, you know, it was the one that showed that a reduction in thromboembolic events that was very real for long term. And, you know, and then an 80-year-old, I still wouldn't give them pegylated interferon. It's not worth the side effects and the hassle for them.
I think your study that you mentioned, looking at the combination of ruxolitinib and pegylated interferon, is very exciting, because you've got the kind of two-pronged attack there in terms of controlling symptoms and disease burden, and then potential disease modification. So I think that would be very interesting to observe. That.
Mary Frances, I'm sorry to have to intervene, but we're running quite short of time, so we've only got a chance for one more question. It's been so active and so wonderful to hear all this, but it's amazing how quickly the time's gone. So there's only time for one more.
Right. So I've various things here that go from various points of view. Some of them are a bit general, so they wouldn't do that. I'll maybe bounce the last question at Allister, because I know he's done some work on this in the past. And this question comes up and is about hydroxycarbamide and the risk of other cancers, specifically skin cancers. And I think, as Allister said, this is real. And we're probably very bad at telling people, particularly in our Northern Ireland population, where the sun and skin cancers go together anyway. Allister, would you like to comment on that?
Yeah, so hydroxycarbamide, I mean, has many decades of evidence behind it. It's a very effective first-line medication for controlling blood counts in ET, PV, some cases of myelofibrosis. But it does have risks and side effects, and one of them is of skin problems. So it's important as clinicians we identify those people that are at high risk of skin problems because of either previous skin problems that they've had, such as skin cancers or precancerous skin conditions, history of excess skin exposure, or a history of ulcers in the skin. Hydroxycarbamide in the studies has been associated with a slight increased risk in some types of skin cancer, in what's called non-melanoma skin cancers. So it does not appear to increase your risk of malignant melanoma, which is the most aggressive and serious of all the skin cancers, but it can increase your risk of squamous cell carcinomas and of basal cell carcinomas, or the other term for basal cell carcinomas, which is sometimes used as a rodent ulcer. It's important that people take steps to minimize their sun exposure, even in such a cold and rainy place as Northern Ireland. UV exposure is still ever present. So my general advice would be that whenever I have a new patient and we're discussing first-line options, for instance, for ET and PV, that where patients are don't have any clear factors that indicate one over the other, I will offer both hydroxycarbamide and interferon almost as an equal footing as a first-line option. Hydroxycarbamide would be something that I would have to think much more carefully about in people with a history of skin cancers or skin problems. And what I want to do is give people as much information on what they can do to try and reduce their risk in the longer term, because hydroxycarbamide is a long-term treatment. So simple steps that people can take would be a wide-brimmed sun hat on sunny days, avoidance of midday sun, using high-factor skin block on sunny days or on holidays, and then examining themselves and addressing and getting a medical opinion on any new skin conditions that they experience during this that may impact them down the road. And I'll just make a final point about skin ulcers, particularly on the ankles. People with poor circulation to the legs or with diabetes would be at increased risk of skin ulcers in the legs. Hydroxycarbamide does appear to increase your risk of skin ulceration, and that is something that you need to let your treating team know about straight away. If you're on hydroxycarbamide, that is key that we know about that as soon as possible.
Okay, thank you very much. So I think we have to stop now. Our Nona's going to have a bit there, so I'll hand it back to Nona to close the meeting. But that was
all I can say is we could have gone on for quite a bit longer. And I can't thank you enough as a panel. You've been absolutely superb. And I think everybody will agree that we've had a really fantastic Belfast virtual forum. Sadly, it's the last planned one this year, but Maz and I are very much hoping to be on the road again next year, COVID permitting, and so that we will be able to meet you all in person. But a huge thank you to giving up your Saturday morning to all the clinicians and to Margaret Cooper. But there's just two other people I want to thank. And in the background, there is Danny Palmer. And Danny has been just amazing. She is the event executive for the Commercial Service Directorate at Guy's and St Thomas's Foundation, and responsible for getting us all doing the right thing with our internet and correcting things that happened. Danny, I know you've given your own time to help us, and I cannot tell you how grateful we are, especially to somebody who started off being very terrified and ignorant about the internet. So I'm just saying, and also one other big thank you to Maz. Maz is the person who holds MPN Voice together. And Maz, again, we can't do without you. And I'd just like to say a huge thank you. You know, we're in a very difficult situation at the moment, but we do give thanks to everybody who's there to help us. Please could you fill in the feedback form so that we can look at making improvements or meet the needs of the patient community. And a final thank you to Novartis for their support. And just a message to you all, please stay well and keep safe. And we really look forward to seeing you again soon. Thank you all.